Simplifying, excuse me, simplifying MIPS and APMs. I am Nathan Brown, Director of Marketing at Spectrumetics. I'm going to be your moderator today. A few housekeeping items before we get started. We will be sending out an ebook of the webinar to attendees post-webinar. If you have any questions during the webinar, please enter them into the questions field of the control panel, and we will answer them at the end. And we're also going to be conducting 2 poll questions during the webinar. So if you don't mind, please take a moment to answer because we value your input. Our panelists today are Dr. Raj Lakhanpal. Dr. Lakhanpal is the Chief Executive Officer of Spectrumetics. He's also a member of the HIMSS Clinical and Business Intelligence Committee, on the governance board of MITA. He's also a member of the Board of Trustees of the University of Sciences. And then we have Mark Bryant, who's Director of Sales at Spectrumetics. Mark is responsible for all new business development and client relations, and formerly was with Sun Microsystems and Iron Mountain. Our agenda today, we're going to do a brief introduction about us. We're going to give an overview of the MAC-Refiner rule. Then we're going to talk more in depth about MIPS and APMs. And finally, we will talk about the Spectrumetics e-measures for MIPS platform. So without further ado, I'm going to hand it over to Dr. Lakhanpal.
Hello, good morning, everyone, and good afternoon. It's my pleasure to present to you along with Mark Bryant. So before I begin, I'm going to take a couple of slides, talk on a couple of slides about us, about Spectrumetics and what we do, so that at least some of you may not have heard of us, or maybe coming to the webinar for the first time. So we assist our clients in transitioning to value-based care. As a company, we've been around for 7 years, and our core mission, our reason to live, is to assist our clients transition to value-based care. And we do it with 3 main core competencies. One is data aggregation, collecting data from different sources, and then we warehouse it, and then we also create visualizations. The second competency that's very important for this discussion is measures, calculation, and reporting. So we have a library of about 400 measures, and Mark's going to go deeper into it. MIPS measures, ACO measures, disrupt measures that we leverage to help create solutions around value-based care. And third is population health. Population health, financial modeling, and profiling, the entire suite to enable you to do population health. Some of our clients, just want to take a minute to talk about them. We have a number of clients with Medicaid reform in New York State. You see the 4 ones, Mount Sinai, Staten Island, yes, Alliance is in Albany, Finger Lakes is in upstate New York, in the Rochester region. With Mount Sinai, we're also working with their CIN, Clinically Integrated Network, as well. Then MIPS, we have a number of clients in MIPS and TCPI, LA Care being one, and then Mid-Michigan Health and others. And then we have clients, so ECQMs and hospital analytics. And on the right side shows some partnerships. We've partnered with a number of HIEs to integrate with them. We've also partnered with a few care management companies, and also all our measures are certified by the ONC. All the ECQMs, both on the hospital side and the ambulatory side, are certified by the ONC, and we were also involved in a pilot with NCQA where we helped them develop the EHEDIS measures. So enough about us. I'm going to now move to the program. So MACRA was recently legislated in the last quarter. And with MACRA, CMS ended the SGR, which is a sustainable growth rate formula. That was how physicians were paid, or their spending or the reimbursements to physicians was increased every year. So that was sunsetted, and MACRA was passed. And the goal of MACRA is to incentivize providers to improve quality and outcomes and reduce costs, as you will see. And it combines three programs that were already in existence: Meaningful Use, EQRS, and VBPM. And as I mentioned earlier, it ends the sustainable growth rate. So MACRA, the payment programs are called QPP, which is Quality Payment Program. And there are two types of QPPs. One is MIPS, and the other is APMs. MIPS is called Merit-Based Incentive Payment Program, and APM is Alternative Payment Models. So talking of MIPS first, it's a performance-based program, and it provides an adjustment, hopefully an incentive, to your Medicare reimbursement. And it is for Medicare Part B participants. APMs, there is a greater earning potential, but there is a risk involved with that too as well. And we'll talk briefly of APMs. You participate through an advanced APM care model, and we'll talk of that. Who's eligible for 2019 or 2017 they're called EPs, eligible professionals, and these are physicians, physician assistants, nurse practitioners, CRNAs, clinical nurse specialists, and CMS estimates that out of 1.3 million Part B clinicians, close to half would be eligible. About 600,000 are MIPS eligible, and another 100,000 will be participating in the APM track. Who is not eligible? So physicians or residents coming out of a residency program in their first year, they're not eligible. And then if your volume is such that you have a Medicare billing of less than 30,000, or provide care to 100 or less Medicare beneficiaries or patients, then you're not eligible. And also certain participants, certain providers in an APM model. So if you're involved in an advanced payment model, then you may not be eligible. But please do keep in mind that MIPS is at a provider level and APM is at an organization level. So even though you're in an APM, you might be eligible to eligible to be part of MIPS. So keep that in mind. And the reporting options, like in EQRS, you can report either individually or through a GPRO as a group. And also the reporting can be used through a qualified registry as a QCDR, or through a QCDR, through ECQNs with your electronic health records, or with claims. When does QPP start? So Quality Payment Program. It started already, as I mentioned earlier, you have to report for 2017, so it started on January 1. And so you could start collecting the data today. There are different programs within MIPS. I'll talk of them in a minute. You could also elect to only provide data for 1 quarter. And the last date for you to collect data is October 2nd, because then only you can submit data for 90 continuous days. And you have to send in your performance data by March 31st. And Medicare gives you feedback, and then the first payment adjustment starts in January 2019. So it starts now, already started. The payments, the adjustments will happen in 2019. And the adjustments are for reporting. Not reporting is a -4%. So for not reporting in 2017 is a -4%. So you could also, given how you perform, you could have an incentive of up to 4%. So the delta is minus plus 4%. And then it goes up to, by 2022, it goes up to 9%. So the delta there is 18%. So very significant adjustment based on how you perform. And if you're part of an APM, then you can earn a 5% lump sum incentive payment for participating in the APM, but you will also be taking on some risk as well. If you are an APM that qualifies, you do not need to report for MIPS. Also, there's a reputational impact to this. There's some data. There was data from JAMA that 65% of the consumers are aware of online provider rating sites. 35%, close to 35%, reported selecting a physician based on how they've performed, and in the same percentage, in the same range, they avoided a physician based on their performance as well.
Thanks, Dr. Lockenbach. So we're going to pause and do our first survey, first poll question. What is your biggest challenge with the upcoming transition to MIPS? I'm going to launch the poll now. I'll give everyone about a minute to answer. Okay, I'm going to close the poll. Share the result. Collecting the data necessary is by far the biggest answer, followed by identifying measures. Identifying measures, activities reflecting best performance. So moving on, I'm going to hand it back over to Dr. Lockenbach.
So the next 2-3 slides are important. This slide talks about the various MIPS performance categories. You have quality that replaces PQRS. You have, in the top 4 rectangles, you have clinical practice improvement activities. That's a new category. You have advancing care information. That's the old meaningful use compliance. And then you have cost. So in the earlier proposed rule, CMS had put cost at 10% for 2017, but then based on feedback, they've removed cost, and it's at 0% for 2017 reporting. Quality is 60%. Clinical CPIA is 15%. ACI, advancing care information, old meaningful use is 25%. And as I mentioned earlier, cost is 0. But cost jumps up to 30% in 2019, and also, quality goes down from 60% to 30% by 2019. So within quality, keep in mind that earlier, when PQRS, you had to report per EP, you had to report 9 measures, or as a GPRO, 9 measures across 3 domains. Within MIPS, it's 6 measures for every EP, or 6 measures for a GPRO reporting. and out of which one needs to be an outcomes measure. So that's important. And the example of an outcomes measure, there are 65 outcomes measures. And for example, an example of an outcomes measure is depression remission at 6 months. So that's an example of an outcomes measure. Perioperative temperature management. Also, this time around, there are 26 specialty sets or subspecialty sets. So if you have a group of cardiologists or GI physicians, they can leverage the specialty sets. And most specialty sets will have more than 6 measures, but they can pick 6 out of them. Or you can pick 6 that are most advantageous to you and report on those. And this replaces the old measure groups, which are more disease-specific. So based on feedback, instead of disease-specific groups, now CMS has advanced to specialty sets or subspecialty sets. Moving on to clinical practice improvement activities, there are about 92 of them. These are all new. You will need to collect data for at least 90 days on them. And the example is, for example, implementation of fall screening and assessment program as a clinical practice improvement activity. Implementation of chronic, condition-specific chronic disease self-management support program. So those are some examples of clinical practice improvement activities. And advancing care information, as I mentioned, was old M. Happy to answer questions after the presentation about the MIPS performance categories if you need further clarification. So this is also, for 2017, you can pick your own pace. So, based on feedback, CMS said, look, if you are not ready, you can test the payment program where you submit some data. So that if you submit some data, it prevents or avoids a negative adjustment. So you will not get -4%. You'll be at 0. And you need to report and achieve 3 points, and that you can get by reporting 1 measure or 1 clinical practice improvement activity. And I talked about that there are about 92 activities you can pick from. 2 is participate for a quarter. So if you submit comprehensive data, and we'll talk of that in a minute, for 90 days. And it allows for a small positive adjustment. 3 is you submit data for the entire year, the comprehensive data, and that allows for, a moderate. The CMS is being a little conservative. It allows for, it depends on how others do, but that can give you a good positive payment adjustment. But there is also, if you have not done well, there is a risk of a negative adjustment. And 4th is if you participate in an APM, and the examples are Medicaid shared savings, track 2 or 3, where you don't need to report for MIPS, but you also, in that case, get a 5% incentive payment as well, or up to a 5% payment. And these are the categories, again, reporting some data. As I mentioned earlier, you can report on 1 measure or 1 activity, or for advancing care information, 5 required measures. But if you want to do track 2 or 3, where you're reporting for some period, 90 days or the full year, then you have to report 6 measures, and as I'd mentioned earlier, out of which 1 needs to be an outcomes measure, or you can report 6 measures out of a specialty set. And in that case, you need to report on 4 clinical practice improvement activities and 5 measures for advancing care information. For example, meaningful use, e-prescribing are some of the examples of advancing care information. So moving from MIPS to APMs. APMs, you have to have certified EHR technology, number 1, and the payments could be up to 5%, so they're comparable to MIPS. And so for APM requirements, you could be a medical home expanded under CMS Innovation Center Authority, or you can require your providers to take on risk. And the next slide talks about that. So the 2017 advanced, excuse me, advanced payment models that have been approved are the comprehensive end-stage renal disease care model. This is a list of all the models that have been approved. CPC, Shared Savings Program Track 2 and 3, where there is greater risk, Oncology Care Model, and the Comprehensive Care for Joint Replacement, and then Vermont Medicare ACO Initiative. So these have been approved by CMS. The next ones are under consideration or development, and I won't read the list, but these are the ones that are under consideration right now. So this completes my part of the presentation. Thank you for your time. We'll be staying back to answer any questions afterwards.
Thank you, Dr. Lockenthal. I'm going to pause again to conduct our next poll question, which is, what is your biggest technology need to transition to MIPS? Launch the poll now. Everyone about a minute to answer. Okay. Close poll. Results. So MIPS data integration from multiple sources is the highest selected, followed by aggregating governing data for MIPS calculation and submission. Thanks everyone for participating. Now I'm going to hand the presentation over to Mark Bryant.
Thank you, Nathan, and appreciate everyone's time today. For my section, I'm going to spend a few moments talking about how we can support MIPS, APMs, and other initiatives your organization might be undertaking in 2017 and beyond. So to start off, what we see as the 5 key areas to prepare for MIPS reporting is number one, and we've seen this in successful implementations we've had with other clients in PQRS and other programs, is to go with a collaborative approach within your organization. Make sure multiple stakeholders are involved, from your finance to your quality and clinical teams to information technology. Second is what we call is a readiness assessment process. Understand where you stand today against the measures that you might be selecting for your providers before you go into implementation, so that you can start to select the right measures to maximize use of incentives today and build upon them for tomorrow. Third is optimize and understand 2016 PQRS and meaningful use activities that you've conducted, because these translate to the quality measures in advancing care that will play up to 85% of your composite score in MIPS for 2017. So that's very important for that. Number 4 is the ability to track performance by provider for measures and activities. So even if you're reporting as GPRO, you're going to be wanting to be able to benchmark which of your providers are performing well and which are underperforming, so you can work with the ones underperforming to improve their scores, which will ultimately improve your ultimate incentive opportunity. And the last piece, and even though cost isn't a component for 2017, start to evaluate current versus expected costs and resources so you can get ahead of that area as well as cost grows in importance in 2018 and beyond. So as Dr. Acapala stated, we have 3 core competencies at Spectrumetics, and I know the poll questions showed a lot of areas of a need around data integration. I'll spend a few moments on this, but the first piece of it is our ability to consolidate data across disparate systems. And so different data sources that we're working with today, both the hospital EMR for clinical data, working with ambulatory EMRs to combine their data if they're on different sources, integrating with HIEs to bring in clinical data, doing a lot of work around billing data as well for PQRS and other programs, taking in survey data, meds data, ADT feeds, and other custom feeds. We aggregate that data, apply our own enterprise master patient index to it to normalize it, and then populate an enterprise data warehouse for our clients. And in an upcoming slide, I'll talk about the methodology and how we get the data, but we can help you bridge that gap with multiple data sources in order to get your arms around it for reporting on measures and also analytics. So our measure platform, we're certified for all 29 hospital electronic clinical quality measures, so we can satisfy HIQR meaningful use in the Joint Commission. On the ambulatory side, and what's most important for this presentation today, is we're certified for all 64 ECQMs, and we're for ambulatory, and we're also a qualified registry, so we can support all measures for MIPS. We're working with clinically integrated networks. We have measures to support that. If you have an accountable care organization, we have measures to support ACOs as well. We have a full library of HEDIS measures for STAR and pay performance programs. We're doing a lot of work today around Medicaid reform, both in New York State with Disrupt, and also California with their prime and whole person care. And if you're involved in another state's Medicaid reform, our platform can easily scale to those. And we can build custom measures as well. So we feel this is our biggest strength, that we can be a one-stop shop for our clients to help them manage multiple programs. And then the third piece, the third leg of our competencies is our analytics, and speaking specifically to the advanced alternative payment models, we can aggregate the data, populate our enterprise data warehouse, and then be able to provide you analytics to support patient flagging, disease registries, tracking assigned lives, providing risk, and doing risk stratification using common or industry models out there. And we have a data analytics team that takes those common models and makes them more effective through other data sources and methodologies, so we can provide you risk to track your members, doing physician scorecarding, geo-mapping, hotspotting, and other areas as well for you. I'm happy to talk in more depth on that separately from this. And so getting to how do we take in data, and so we see there's three main ways that we've been working with our clients to take in various data sources. The first is through a structured format. So if your EHR can produce a QRDA or CCDA, we can ingest that data source. The second is what we call intelligent chart abstraction. So we can utilize billing and claims data for any data that's missing, any G codes that might be missing. We could provide smart web forms to help you populate those areas and ingest that data. And then the third area has a couple different pieces for it. So first, we can build interfaces into your EHRs and work with multiple EHRs today. We can ingest flat files in as well. But what we've seen as most effective for our clients to date is what we will understand which measures that you're looking to report on for your various programs or which analytics that you need. And we'll build out what we call our data specification file that'll list the specific elements that we need to calculate those measures. We'll provide that back, and then your team can run a report to provide that information to us. And that's been very effective in areas where a standard format couldn't be given, or they were short-staffed in IT. Various ways we can help. Once we have that data, we then layer our measures or analytics around it, and we provide dashboards, and I'll show you an example of that in a second. We create the submission file to support for CMS, for Joint Commission, and other programs. And then we can satisfy multiple programs. So listed here is what we were talking about today underneath MACR with MIPS and alternative payment models, but we can also support TCI and clinically integrated network and Joint Commission and other areas as well. And So speaking specifically to our MIPS benefits by category, so for the three core categories for this year, for quality, we're going to be supporting all MIPS measures underneath the quality category. We're a qualified registry, and we have a proven track record in calculating and reporting PQRS for our clients. For improvement activities, we can calculate and report on the improvement milestones. We have experience in this underneath both our work with TCPI grants and also our work in New York Medicaid reform with Disrupt. Advancing care information, we can provide you back dashboards to attest on those measures and report that as well underneath the old meaningful use category. And also cost. So again, even though cost isn't a component today in your overall composite score, we can provide you analytics around cost and utilization so you can start to determine how you fall today and start to improve upon it so that when it becomes a component next year and beyond, that you're ready for it. So in our portal, we have a couple of key roles. Security is a huge part of our culture here, and to protect that for our clients. And so we separate PHI out by roles and work with our clients on that. So, but we see it as a couple different roles that we can offer. The first is an executive role. So an executive role at your organization is going to be able to see enterprise-wide performance. So if you're tracking multiple tax identification numbers for your organization for MIPS, you'll be able to go in, see as an overall performance for those TINs, then be able to drill down into each of the individual TINs to see their performance for each of the three categories, and then start to drill down into the measures and activities that support each to see how you're currently doing for that, and be able to do provider comparisons as well. Attached to that role is what we call an analyst role or an informaticist role. So the analyst role picks up from where the executive leaves off in terms of being able to take the measure and go deeper down and see the patient level details, the PHI, so they can truly do the performance improvement. And this can be done depending on which track that you pick. If you're picking track 2 on a quarterly basis, if you're picking track 3, we'll be able to set this up on a monthly basis to go in and see how you're doing, see if there's any gaps, see why patients might be falling out of the numerator, and be able to do remediation. Tied to that also is what we call a submitter role. And the submitter at the time of submission next year will be able to go in, and if you're tracking more than the 6 quality measures needed to report, can look at which measures are performing the best. Can also look at your improvement activities and your events and care if you're tracking those and you're tracking more than what's needed, and select the ones that put you in the best position to maximize your incentives. We then handle creating the submission files, but the submitter can go back in at any time and view those files. And then the last piece is a provider portal we can offer. And so provider can have access to go in and track their particular patients from an aggregate, and then drill down to see gaps in care, demographics. We can build it out as disease registry, patient registries as well, and then apply our risk stratification to that as another bonus feature. And so a quick look at what our portal looks like, and this is a very simplified look at it. Happy to do our team would be happy to do a demo separately, but an executive up top would log in, be able to see as an aggregate, and then this screen shows if they start to drill down into the specific quality measures that have been selected. So here's a couple of examples that you can see how each of the measures are doing. So typically we set up 2 benchmarks for these. It could be a national average, state average, and then an internal target as well. So you can see for diabetes, hemoglobin A1C poor control, it's outperforming the national average, but currently you're underperforming the internal target, thus it's in orange. The other 2 are green, outperforming both. The last one's in red, underperforming. And then from an analyst role, you'll see that from that measure, from hemoglobin A1C poor control, they can then drill down to see what's driving performance, how many qualify for the denominator, the numerator, who's an exception. So then you can see performance was met, performance was not met, and then if there's any data missing, any G codes missing, if we're taking in just billing data, any clinical data that might be missing as well. And so what we believe differentiates us for our MIPS platform is being able to do, providing to our clients a readiness assessment, a consultative approach up front. So we work with our clients to understand their provider roster and help them. So we do a lot of work before we go into implementation in guiding which measures will best position you today and into the future. Once we have those measures selected, a sampling of those, we'll take in a sample amount of data, run it against those measures, and provide back to our clients a gap, an assessment report which has gaps that might have gaps in it to identify any areas that maybe data is missing, to start to show where measures might be underperforming, where there might be workflow challenges that need to be addressed. And then before we get to implementation, we'll come up with a finalized list of which measures do you want to track today that best position you for 2017 and beyond. And also start to consult if you're looking to become an advanced alternative payment model in the future. How can we help you in that area as well? And so our measure platform is a proven, validated process, and it's been we have a couple steps within it. First, it's verified internally by our measure definition team whenever we're setting up a program, and each year as the measures change. So for MIPS, next year the quality measures might be tweaked. So we go through each year looking at what measures they are, validating them, and then we hand it off to our quality assurance team before we go into production for any of our measures. And we've also been certified externally through CMS. As we stated earlier, we're ONC certified for electronic clinical quality measures. We've gone through the CMS pre-submission validation process. We're a qualified registry. We have joint UGC or vendor certification, and our HEDIS library is going to be certified this year by NCQA. We're currently in process for that. And to summarize our implementation process, so again, the first step is that assessment. There'll be a remediation period. If there's any gaps in the data that we'll work with you on. At the same time, we'll start setting up our portal, start training you on it, launch that once we've remediated any issues. We give you the ability to track it on an ongoing basis, depending on which pick your pace or track that you select. At the time, right before submission, you'll be able to go in, select the right measures that you want to report on, and we provide ongoing support, maintenance, data governance, updating measures as they change year by year, and all of that is included in our services. And to summarize, why Spectrumetics, why we believe we'd be a great partner for you today to assist in MIPS and APMs today. First, we're a qualified registry. We can help with individual, GPRO, and specialty sets. We have history with that. We have experience tracking clinical improvement activities through our clients with TCPI and Disrupt. We have the tools to extract and harmonize different data sources, whether that's claims, clinical survey, self-reported data, and we're doing that today for small organizations and very large implementations as well. We have a library of 400 plus measures, MIPS, HEDIS, NQF measures, etc. And we're very scalable in that. We have a measure authoring tool that sits underneath it, so we can rapidly create and define measures for any programs, for custom programs that you might have, or new programs that come up with commercial payer programs and such. I spoke about our process being validated, and we can provide you a tool, an ongoing tool for real-time tracking that's going to be crucial as you try to maximize your incentives going forward. So that's my part. My contact information is here. Please reach out if you have any questions. If you want to see a demo, me and my team would be happy to work with you on that. I'm going to pass it back over to Nathan now for our question and answer session. Thank you.
Great, thank you, Mark. So we've had a number of questions come in. I'm going to get to as many of them as I can. Joining us for the Q&A is Roger Deschner. Roger's a business analyst with Spectrumetics. He's going to be helping answer some of these questions. All right, so the first one. What are likely impacts of recent political changes on implementation of MACRA and other regulatory programs? Raj is going to answer that.
So, hello again. You know, nobody knows yet. So from what we are told, that MACRA, the passing of MACRA was a bipartisan effort. We told that only 7 Republicans abstained or voted against it. The rest of all the Republicans voted in favor of passing MACRA. So that's all at least we know. So we're moving forward as if it'll be implemented. But that's good.
Thank you, Dr. Lockenpaul. I've heard mixed responses to what patient populations are included in the program. Originally, I heard it was only MCR Part B, but then I heard it has to be 50% of all patients that meet a measure regardless of payer source. Can you please confirm?
Yeah, sure. So I think I'll just rephrase the question to make sure everyone understands. I think the question's asking just to reiterate what the patient population that MIPS will be looking for in 2017 and moving forward. So in PQRS, what currently exists in 2016 is 50% of Medicare Part B population per measure. In 2017 and moving forward in MIPS, that's no longer the case. It does become 50% of all payers in 2017. So that is a very important distinction. There are even plans to expand that to eventually become 90% of all payers to be reported on to successfully report on MIPS as the program continues in later years.
Thank you. So next question, can you explain more how choosing option 3 will put at risk negative adjustment?
So I believe that this is asking for regarding the third option for the tracks as reporting for a full year. For 2017, you likely will not receive a negative payment for choosing to pursue an entire year's program. As Dr. Lockenpaul mentioned earlier, by reporting at least one of the components, you will have successfully avoided the negative payment. So by reporting on a full year, you are putting yourself in a better position to receive that full or the maximum allowed positive adjustment. In later years beyond 2017, there will be that risk of a negative adjustment.
I want to add to that in later years, 2018 on, you will have to report for the whole year.
Right. So that the transition year that's being allowed the option of choosing either one of the components or just reporting for 90 days may not continue to later years beyond 2017.
Okay, thank you, Raj. Next question. Can you report by a combination of group, individual, for the 3 different categories?
That's a great question. So no, you cannot report in a combination of a G-Pro and individual for the 3 categories in MIPS. However, you can report via different reporting methodologies, meaning you can report through a registry for a component, an EHR through another, and perhaps attestation for the last, but you have to be consistent as a G-Pro throughout all 3 or as individual reporting for all 3.
Okay, thank you, Raj. Are there plans to expand these programs beyond eligible providers to include eligible hospitals in the future?
I think that's tough to say. I personally haven't heard too much about this right now. I think CMS is more focused on getting MIPS rolled out and see how it actually impacts the community once it's past the transition year. So I think for the time being that it will remain probably in the eligible provider domain.
A couple more. How long does your MIPS readiness assessment last?
So our readiness assessment ranges from an 8 to 10 week period, and I believe Mark had spoken about it before. What we doing that process, it varies in length based on how much data that we're looking at, the number of measures that we assess, but that's generally the time frame that we look through.
Okay. Next question. Are you working with hospitals now on MIPS?
Yeah, so we, some of our current clients in PQRS that have already transitioned over to MIPS are coming from the hospital domain where they still understand that their providers are subject to MIPS in the coming year and have already begun to make plans for preparing for the program.
Okay. Do you provide any method for users to update existing patient data?
Yeah, so this question, I believe, reflects more towards our portal. As we collect data and display it on our portal, there is also a way for users to kind of update what they're seeing through smart web forms or other clinical extracts to make sure that the data that they're seeing in the portal is the most real-time and most applicable to them. So that is a service that we have.
Okay. Got time for one or two more. If you report as a group, do all providers receive credit for CPIA activities that are only conducted by a subset of providers?
Yeah, that's correct. So similar to how GPRO currently works, as long as you're satisfactorily meeting the requirements, the entire group will receive credit. So that will also remain the same for CPIA and ACI for MIPS.
Okay. And one more. For MIPS, do all providers under 10 on EHR?
I think this is more of a unique question, and I'm sure Mark and our team here would be happy to address this if it required a further explanation. But I don't think there's a specific necessity, but it would help in some of the reporting requirements, specifically in ACI reporting. But I think there's probably more to this question if you would want to reach out.
All right, thank you, Raj. If we didn't get to your question, we will happy to answer it for you after the webinar. Please feel free to reach out to us at the information here. Mark, Director of Sales, will be happy to help you. And thank you, everyone, for attending today. Thank you, Dr. Lockenpaul and Mark and Raj, for participating. And have a great rest of the day. Take care.